Hello, everyone, and welcome to Brainwaves. Today on Brainwaves, I interview Dr. Carrie Bearden, director of the IMRO-funded Center for the Assessment and Prevention of Prodromal States at UCLA. Carrie replaces Dr. Ty Cannon in this capacity this year, and when I hear her speak about her work there, I can tell that she loves her job. And she and her team have taken CAPS and in some exciting new directions this year. Um, and after I present this interview with Carrie, I'm also going to present an interview with Gayle Ayres, a mother of a young woman who has a daughter who participated in CAPS's ABBRC program, about which we'll talk a bit in this interview with Carrie. And we'll hear from Gayle about how her opinions are about how the program works. But first, we'll talk to Carrie. Carrie, Dr. Carrie Bearden, thanks for being on Brainwaves today.
It's my pleasure, Brandon. Thank you so much for having me.
You bet, and you're welcome. So, Carrie, when I interviewed Ty last year about CAPS, he explained a bit about what it was and what it did. But for new viewers, can you please explain what CAPS is and also a little bit about its ABBRC program and what that does?
Sure, I'd be happy to. So CAP stands for the Center for Assessment and Prevention of Prodromal States, which is a bit of a mouthful. Essentially, this is a program for young people that are at risk for developing a psychotic disorder. And the way we define that is based on a set of what we call subthreshold psychotic-like symptoms. So these are young people that are not at the point that they've already had a first break of psychosis. They're basically experiencing early symptoms that seem to be warning signs that a psychotic break may be impending. So, for example, things like having unusual thought content, starting to be suspicious about people around them, starting to be suspicious or withdrawing from friends and family. Sleep disturbance, depression and anxiety. Those are some of the very non-specific signs. Typically, these young people also start experiencing, concerns about maybe seeing shadows or possibly hearing whispers or noises. And these are new experiences that are starting to become distressing for them. So that's how we essentially define the clinical high-risk population and individuals that we think are at risk for developing a psychotic disorder. Now, that being said, only about a third of those individuals will actually go on to develop a full-blown psychotic disorder. And so I'll tell you more about that in a moment. But one of the things we're working on is trying to improve our predictive algorithms. The Adolescent Brain Behavior Research Clinic, or ABBRC program, is one that we started for adolescents that are already experiencing full-blown psychotic symptoms. So adolescents with a diagnosis of schizophrenia or schizoaffective disorder or a psychotic spectrum diagnosis. And the reason we started this program was essentially because we had so many young people coming in to who had a referral for CAPS. And we were actually very surprised to learn that many of them were, unbeknownst to their family, had already experienced a psychotic break.
Wow. Okay. So you try to help. Not only do you do research with these young people as volunteer subjects, but you also help intervene to help them with if it's with the ABBRC, their early symptoms, or with the general CAPS program, their prodromal symptoms. And I understand that, as Ty explained before, but perhaps you can elaborate too, on the main approach that CAPS uses to help its clients, that is to say, is a whole family-oriented approach where you engage the family in psychoeducation and develop family communication skills and also help the family to solve problems cooperatively through counseling. Um, in what ways would you say these techniques benefit the client and the family?
So I'm a big believer in this approach, particularly in these early phases of illness, where I really think that a psychosocial intervention approach is going to have the most impact. And I think from all the research, we really can see that there's very good evidence that earlier intervention makes a big difference. And the reason that the family environment is so important, I think, is anyone who's experienced a psychotic disorder it particularly in the early phases, is this is not something that affects one individual. It really affects the entire family system, and the family is often really struggling to understand what's going on, and frequently they have no idea, and often the young person who's experiencing the symptoms is blamed for example, being lazy, or, you know, having trouble getting out of bed, not doing their chores. And so just the whole construct of that, these are negative symptoms. It's not, you know, that they're lazy. I think this is actually, I think, one of the areas where our interventions with the family make some of the biggest difference, is just in terms of psychoeducation around the kinds of symptoms that this young person is experiencing, and that they really are experiencing some biological changes in the brain that are leading to these difficulties. So improving family communication is a big focus, and one that we found that actually makes a really big difference.
Yeah. So, okay, well, great. In addition to the psychosocial interventions, CAPS also, and the ABBRC, also in cases when a young person has determined to have some psychotic symptoms, and in other cases that are related, there sometimes will be medication prescribed, or even a cessation of other medications prescribed by other psychiatrists before they came to CAPS, if it doesn't seem like they're appropriate for the young person. How do you find that medications can be helpful or not when somebody comes to you for an early intervention situation?
Yeah, it's a great question, and we in terms of prescribing antipsychotics, we try to be pretty conservative in terms of prescribing them really only when they're clinically indicated for psychotic symptoms, and when the symptoms have become distressing and functionally impairing. So that's really our threshold for when we would prescribe an antipsychotic medication. And I think in the community, atypical antipsychotics are prescribed increasingly for other kinds of symptoms like sleep disturbance and behavior problems. And so we really try to, when young people come in on a lot of different medications, we really try to partner with the psychiatrist in the community, and we really try to get a better understanding of, you know, what is that medication targeting, and have you found it to be helpful, and, you know, what happened when you increase the dose. And so we don't, you know, take a adversarial approach, but we really try to understand the rationale for the different medications. And sometimes if there isn't, then we partner with the treatment provider and really say, okay, well, let's just see what happens if we reduce this medication gradually, or we take them off this, and see how things go. Because, I mean, one of the big questions families often have is, you know, does my child need to be on this medication forever? And, you know, I think probably the answer is no, but we really don't have the data to say that for sure. So we try to take a very symptom-focused approach in terms of you know, medications to target particular symptoms, and then also pretty empirical to look at, you know, is this medication really doing something? Is this actually helping this, you know, this young person? So we try to, you know, basically look very closely at the trade-off between the positive, you know, the benefits of the medication versus the, you know, any kinds of adverse effects.
Okay, that sounds very appropriate. So you told me earlier that CAPS is now offering as a group for its group programs, or the ABBRC, excuse me, is offering for its group programs a cognitive behavioral, dialectical behavioral therapeutic discussion approach. Why did you start to offer this approach, and how have you found that it benefits the clients?
Yeah, so that's a great question. It's actually a very creative therapeutic approach, which was developed by one of our psychology interns, Maria Jabkowski, and Peter Bachman, who's a junior faculty member here. And so essentially, their belief was that, so we know that for adults with schizophrenia, cognitive behavioral therapy can be very effective as a way of not necessarily challenging one's beliefs, but really trying to understand the rationale for, a belief, for example, that someone, a delusional belief or a hallucination. And so really trying to, have patients focus on what the rationale is for those beliefs. And so this cognitive behavioral therapy approach, we know has been effective. But one of the things that we've noticed with the adolescents with schizophrenia is that they tend to have a lot more mood disruption than what we see in adult patients with schizophrenia. And so this mood lability we thought was something that was going to be really important to target with another kind of approach, which is dialectical behavior therapy, which is an approach that's been very well validated and is very focused on improving mood regulation. And so the combination of those two approaches, Maria and Pete actually found to be very helpful for adolescents. And so this group, the adolescents really enjoyed being there and really appreciated, the kind of, well, there's first of all, they really enjoyed being in a group with other adolescents that were going through the same thing. I mean, that's sort of number one with any kind of group. And I think for adolescents where there's a big peer component, that was particularly helpful. And then the particular components of the therapy they found to be very helpful, both in managing their symptoms as well as their mood.
Great. That's great to hear. Well, I'm glad CAPS is incorporating some emerging therapeutic techniques in addition to tried and true traditional psychiatric techniques in its preventive programs, and it has had such great results. So carry on, and thank you so much, Carrie, for being with us on Brainwaves today.
Oh, it's my pleasure. I think it's a great program, so thank you for doing it.
You're welcome. Carrie, if people have questions for you at the end of this segment, would you be ready to answer some questions on the Brainwaves page?
Of course, I would be very happy to. So
okay.
Send them my way.
All right, great. Thanks, Carrie, so much, and I'll talk to you soon.
Okay, great. Thank you, Brandon. Nice talking with you.
You too. Take care. Today on Brainwaves, I welcome Gayle Ayres. Gayle is a mental health advocate, a longtime supporter of IMRO, and also is mother to two daughters. Her younger daughter, Anna, developed, well, she was a musician and an athlete and an honor student and a dancer. When in middle school, she developed symptoms of psychosis and mood disorders. And she was diagnosed with schizoaffective disorder and bipolar 1. And shortly thereafter, she enrolled in the CAPS/ABBRC programs at UCLA. These are the Center for the Assessment and Prevention of Prodromal States / Adolescent Brain Behavior Research Clinic at UCLA. These are funded by IMRO, and in the hopes of getting some advancements for her condition and maybe getting a little bit better. And Gayle is here to talk to us today about her and her daughter's experience at CAPS and ABBRC in 2012 and 13. So, Gayle, you're really courageous to share your family story with us today, and so thanks for appearing on Brainwaves today.
Oh, it's an honor. Thank you very much. Thank you for inviting me.
You're welcome.
Yes.
Yeah, definitely. So, what was the nature of Anna's participation at ABBRC? What did she do there, and how did you participate along with her?
Well, we live about 600 miles away. So what we did was participated in phone interviews. They lasted about 2 to 3 hours. We did that twice. And then we also made the trip to UCLA twice. When we were there, she took part in the research study with interviews and assessments. And then as far as our participation in it, Anna was initially anxious about going to Los Angeles and participating in the program. That anxiety was alleviated as soon as we arrived, but her illness broke through on some occasions during the assessments, And with approval, my husband and I were able to sit in with her, away from her quietly, just to give her a level of comfort to continue with interviews and with assessments.
Okay. So did she receive any treatment as part of her participation?
Um, she was offered to begin the clozapine trial at UCLA, but again, because of the distance, we opted to do it outpatient here with her psychiatrist and her CBT checking in daily, or we sent updates daily. But just the comfort of knowing that we could bring her to UCLA, it was just very comforting to me.
That's
Uh,
great.
yes.
What were your impressions? What were your impressions of the program? And if Anna shared her impressions with you, how did she feel about the program?
Well, she appreciated how compassionate and accessible the interns were during the program. We thought it might be kind of a sterile environment since it is a research study, but the interns, we worked with Sheena and Danessa and Maria, were so non-judgmental, so understanding, and so it made it much easier for her to participate. So she enjoyed the process.
Well, that's great.
Yeah,
I'm glad to hear that. Um, would you say that the program contributed to her well-being, and if so, in what ways?
definitely. After each visit to UCLA, we received clinical assessments. And the first set of assessments that came helped us understand how much her cognitive abilities had been impacted and her nonverbal skills had been impacted. So I was able to use I was homeschooling her at that time and preparing her for the GED. So I was able to, after the assessment, use different modalities in preparing her, focusing more on her verbal skills. So she was able to pass the GED actually a few months earlier than she would have graduated. And then the second visit, it was suggested Dr. Daly and Maria worked together and suggested that she start the clozapine trial. And Anna had tried many combinations of families of medications, and we were kind of running out of answers. And we're on week 18 of clozapine, and we're not there yet, but each week she gets stronger and stronger. And I don't know if I would have had the comfort level with clozapine that I did had we not participated. I'm so glad we started that. And then finally, just learning about prodromal symptoms and therapies, I feel like it helped us to avoid some of the pitfalls that adolescents can deal with this illness. So I feel like she's way ahead of the game. She's still struggles with her illness. It's a devastating illness, but when I think of how far ahead she is at 18 years old, I'm very grateful. So yes, we appreciate all the benefits.
That's wonderful to hear.
Yeah.
So you say some of the benefits are still developing for her at this point.
Yes. Uh-huh.
Yeah. Okay. Okay. Is there anything that you'd like to add for curious parents who'd like to learn more about the ABBRC and maybe for their teens?
I would say talk to your doctor, and if your child can participate, again, it's a research study. It benefits mental health research. I just had no idea how much it would benefit Anna. So I would encourage you to talk to your doctor, your psychiatrist, and see if your child can qualify for the program. I would do it again in a heartbeat.
Excellent.
Yes.
Yeah, that's really great. So thanks, Gayle, for sharing your experience and your daughter's experience with us today on Brainwaves. And if
Thank
people have
you.
any, you're welcome. If
Oh,
if people have any questions for you online, will you be willing to answer a few questions?
I certainly will.
Okay,
Thank you. And
absolutely.
thank you again to you and your family, everyone at IMRO, Dr. Bearden. everyone at CAPS ABBRC, thank you so much. Oh, and especially the benefactors for IMRO. You made a difference in our child's life, and you give me as a caregiver a tremendous amount of hope. Thank you.
Absolutely. You're so welcome. Hearing things like that makes me feel so good about what I do. And
Well,
what we
I
all,
appreciate
yeah,
it.
good. Okay, well, Gail, thanks again, and hopefully we'll talk soon.
Thank you very much. I appreciate it.
Okay, bye-bye.